Hello everyone. Again, I welcome you all to my lecture classes, and this time I am going to take lecture classes on rheumatology. I am going to cover the following topics in my lecture classes. First of all, I am going to take a class on Introduction to Rheumatology or Approach to Different Rheumatological Cases. Then I am going to take classes on rheumatoid arthritis, SLE or systemic lupus erythematosus, scleroderma, spondyloarthropathies. Then I'll cover vasculitis and gout. Okay, so let's begin with our first class, that is introduction class or how to approach to different rheumatological cases. Now, if you look at the prevalence of musculoskeletal disorder, you can see that among the non-inflammatory causes, neck and back pain constitutes the most. That means almost 20% cases are neck and back pain, followed by others like osteoporosis, osteoarthritis, fibromyalgia and all. And if you look at the prevalence of inflammatory causes, okay, rheumatoid arthritis constitutes almost 15% of the cases. One more important noticeable thing is that most of the rheumatological cases are more common in case of females except gout, where it is more common in male. And in case of seronegative spondyloarthropathy, the prevalence is equal in male and females. Now let's look at the classification of musculoskeletal diseases. Can be classified depending on the etiology. Okay, so it can be inflammatory, mechanical, metabolic, neoplastic, drug-induced and other miscellaneous causes. Inflammatory causes again can be divided depending on the etiology. It can be due to infection, can be immunologic, crystal-induced and reactive causes. So, in my lecture class, I am going to cover the immunologic causes of musculoskeletal problem. Okay, that is rheumatoid arthritis, SLE, seronegative spondyloarthropathies, and I will also cover some part of the crystal-induced arthritis, that is gout. Okay, reactive causes may be due to Reiter syndrome, which I'll talk later on, and Behcet syndrome. The commonest cause of mechanical musculoskeletal problem is osteoarthrosis. Metabolic causes may be due to hypothyroidism, acromegaly, Cushing's disease and others. Neoplastic causes due to paraneoplastic arthropathy, also known as paraneoplastic syndrome. Drug-induced arthritis can be due to thiazides, which causes hyperuricemia, in turn leading to gout, and there are certain drugs which can cause lupus also. Okay, now coming to the symptomatology of rheumatological diseases. Okay, if we talk about the symptoms, the commonest symptom is pain. Okay, the pain may be of different types. Okay, pain may be due to while using a particular joint, that is usage pain. Pain may be at rest. Okay, when a particular joint is at rest, the patient may have pain, or there may be bone pain also. Okay, then stiffness of joint, patient may complain of stiffness, which is a sign of inflammation. Then patient may complain of swelling of a particular joint. Okay, swelling may be due to accumulation of fluid or may be due to soft tissue swelling. Patient may come to us with deformities. Okay, bony deformities in the joint, and sometimes patient may come with only systemic symptoms like malaise, fatigue, fever, sweating, etc. Now, in this image, we can see that the different diseases, okay, involves different joints. So, depending on the involvement of joint also, particular joint also, we can think of certain specific diseases. Just for example, take DIP joint, okay, distal interphalangeal joint. In rheumatoid arthritis, metacarpophalangeal joints are affected, proximal interphalangeal joints are affected, but it rarely affects DIP or distal interphalangeal joint. So if there is involvement of distal interphalangeal joint, first we should rule out other diseases. Okay, it will be very less likely a case of rheumatoid arthritis. Okay, now on examination, what you should do. Okay, a patient has come to you with complaints of pain, stiffness, swelling, etc. Now what you should do on examination? You should look, you should feel, you should move the joints and see the response. Okay, look stands for inspection. Feel, you should palpate and move. On active and passive movement, you should see what is happening. Now inspection, what you're going to see on inspection, what you're going to look for. You should look for any skin changes, okay, any wasting, any swelling, or any deformity. Then inspection during movement. Okay, while doing active movement, okay, you should see if there is any restriction of movement or there is any pain while moving the particular limb or particular joint. Okay, then you should do a palpation. On palpation, what are the things you're going to see? You should examine if there is any tenderness, any warmth, any swelling, any crepitus you can feel. Okay, stress test. Okay, stress pain is the earliest and most sensitive sign of synovitis. Okay, inflammation of the synovial tissue. Then you should do active movement and passive movement, and then you see whether the patient resists or not, if there is any restriction of movement or not, if there is any pain or not. Okay, so these are the things we're going to examine when a patient is coming with the symptoms of any rheumatological disease. Okay, just for your knowledge, just remember that the symptoms like stiffness, sign and symptoms like stiffness, warmth, effusion, stress pain, these are features of synovitis or synovial inflammation. Whereas crepitus and joint deformity, okay, crepitus and deformity are characteristics of joint damage. Okay, this is how you differentiate if there is involvement of synovial tissue or if there is joint damage. Now there are certain clinical clues. Okay, the pattern of joint involvement. Okay, whether inflammation is present or not, how many joints are involved. If single joint is involved, we know it as monoarticular. If up to 4 joints are involved, we know as oligoarticular. More than 4 joint, we know it as polyarticular involvement. Okay, then which joints are involved, that is very important. Okay, as I have already mentioned, depending on the pattern of joint involvement also you can identify a particular disease. Now in certain diseases, rheumatological diseases, there will be extra articular symptoms also. There may be presence of fever, rash, nodules, neuropathy, Raynaud's phenomena, many other extra articular symptoms may be present. Okay, that we're going to discuss later on. Then history. In the history, it is very important to take the history of drug use like diuretics and aspirin, which can cause gout, phenytoin and certain other drugs, other antiarrhythmics, antipsychotics drugs which can cause SLE, steroids or statin which can cause myopathy. Family history of rheumatoid arthritis is very important. Then social history, alcoholism, past medical history of trauma, these things you should be asking. Now in the clinical assessment, okay, you should remember the examination as Gall's screen. Okay, Gall stands for, G stands for gait, A for arms, L for legs, S for spines. So when a patient is coming with the complaint of pain, restriction of movement, swelling, etc., then you should be examining patient's gait, patient's upper limbs, patient's lower limbs and spine if you think of a musculoskeletal disease. How do you approach? Okay, it is very important. How do you approach a case of musculoskeletal disorder or rheumatological case? Okay, first of all, you should know if it is an acute condition or it is a chronic condition. Next thing, you should know if it is an inflammatory condition or non-inflammatory condition. Next thing you should be knowing if it's a monoarticular, polyarticular, focal or widespread disease. Then you should differentiate whether it's an articular condition or a non-articular problem. Okay, and whenever you are thinking of a disease, think of the most common things first. Okay, that is very important in medicine. Okay, you should be thinking about the most common disorders first, and then you formulate a differential diagnosis. Okay, these are certain images of deformity. Okay, in case of different type of arthritis. Okay, these deformities we see in cases of rheumatoid arthritis. Okay, late stage of rheumatoid arthritis, boutonniere deformity, then ulnar deviation of metacarpophalangeal joint, swan neck deformity. Okay, these are very typical of rheumatoid arthritis. Okay, this type of deformity also we can see sausage disease, telescoping, swollen joints, dactylitis, all these things. Okay, claw finger, rough, rigid and thick skin. This usually we can see in cases of scleroderma. Jacquard's arthropathy also we can see. Then here you can see some nodules. Okay, nodules in the proximal interphalangeal joints known as Bouchard's nodule, nodules in the distal interphalangeal joint known as Heberden nodes. These are found in cases of osteoarthritis. Okay, so when a patient has come to you with certain deformities, okay, just looking at the deformities, just by examination of the deformities, many times you can diagnose the particular disease. Okay, suppose the patient is coming with this type of nodes, Bouchard's nodes and Heberden's nodes, then you can think of osteoarthritis. Or if a patient is coming with swan neck deformity, boutonniere deformity, ulnar deviation of MCP joints, then you can think of the patient is maybe having rheumatoid arthritis. Now, how do you know if the disease is inflammatory or non-inflammatory? Okay, in cases of inflammatory disease, the patient will give certain very important or catchy history. Morning stiffness for more than 1 hour. It is very important. Morning stiffness for more than 1 hour, and there is improvement of stiffness on usage. Okay, when the patient starts using the joints, okay, then the stiffness slowly goes off. Worsening of symptoms at night, constitutional symptoms like malaise, fatigue, all these things. And on investigation, elevated ESR, erythrocyte sedimentation rate, okay, CRP and other acute phase reactants are raised. So these are the catchy points by which you can know if the disease is inflammatory or it is a non-inflammatory one. Now, in the approach, one more important thing we have already mentioned, that you should identify if it is an articular problem or it is a non-articular problem. Now, how do you know it? There are a few points I'm going to mention by which you can know if the joint is involved or the involvement is non-articular or periarticular involvement. Tenderness. In case of joint involvement, the tenderness will be over the joint, whereas in the periarticular problem, it will be away from the joint line. Restriction of movement, both active and passive movement will be restricted in case of joint involvement, whereas in periarticular cases, active movement will be more restricted than the passive movement. Okay, the resisted active movement will not be painful in case of joint involvement, but in cases of periarticular involvement, it may be painful due to involvement of muscle, ligaments, etc. Stress pain, there will be stress pain in all direction in cases of joint involvement. Okay, but in case of periarticular involvement, it will be only in one plane. And if on examination, if you find any crepitus, okay, in case of joint involvement, the crepitus may be coarse or fine, but in case of periarticular involvement, the crepitus will be fine. So these are certain points by which you can know if the involvement is of joint or it is of periarticular involvement. Okay, now if you look at the algorithm, okay, if you look at the algorithm, how to approach a patient, okay, who is presenting to you with complaints of, as I have already mentioned, complaints of pain, swelling, restricted movement, stiffness, all these things. Now what you do, how do you approach? Okay, this also we have already mentioned. You should know if it's an articular problem, if it is an acute or chronic, if it is an inflammatory condition or non-inflammatory condition, and how many joints and which joints are involved. Okay, if it is acute problem, if suppose it's an acute problem, it is monoarticular, focal or monoarticular problem. If it is so, then the conditions may be gout, septic arthritis, maybe due to fracture, vascular ischemia, and carpal tunnel syndrome. Okay, if no, then you should judge if it is an articular problem or periarticular problem. Okay, non-articular problem. If it is not an articular problem, then what are your differential diagnosis? Okay, the differential diagnosis could be due to trauma, fibromyalgia, polymyalgia rheumatica, bursitis, tendinitis, okay, myopathy or myositis. If it is articular, then you should ask about the duration of the symptoms. Okay, if the complaint is for less than 6 weeks, okay, if it is for less than 6 weeks, okay, and if it is acute, okay, less than 6 weeks is considered as acute problem. Okay, so your DDs will be acute arthritis, septic arthritis, gout, pseudo gout, reactive arthritis, okay, or initial presentation of chronic arthritis. If the complaint is persisting for more than 6 weeks, then it is a chronic condition. And if it is chronic, you should know if there is presence of inflammation or not. Okay, if the signs of inflammations are present, we have already discussed how do you know if it's an inflammatory or non-inflammatory condition. If the signs of inflammations are present, okay, then it is a chronic inflammatory arthritis. Now once you know that it is a chronic inflammatory arthritis, you should know how many joints are involved, because in different diseases the number of joints involvements are different. So if 1 to 3 joints are involved, it is mono or oligoarticular condition. Okay, it may be due to TB or fungal infection, psoriatic arthritis, reactive arthritis, polyarticular. Okay, if it is polyarthritis, okay, here they say more than 3 joint involvement is polyarthritis. Okay, but some books will say more than 4 joints involvement is polyarthritis. So chronic inflammatory polyarthritis, you should know if the problem is symmetric or not. If the involvement is symmetric, okay, then you should know which joints are involved. If PIP, MCP, MTP joints are involved, then it goes in favor of rheumatoid arthritis. If not, if these are not the joints involved, then it goes in favor of SLE, scleroderma or polymyositis. If the involvement is asymmetric, okay, think of psoriatic arthritis, reactive arthritis or enteropathic arthritis. Okay, if the case is chronic, okay, the duration of symptom is more than 6 weeks and there is no inflammation present, that means you think that this is not a inflammatory condition, so it will go, you can think of non-inflammatory arthritis. Okay, in non-inflammatory arthritis, if DIP or first carpometacarpal joint, hip or knee joints are involved, then you think of osteoarthritis. Okay, and if these joints are not involved, then you can think of other, it is unlikely to be osteoarthritis, you can think of other non-inflammatory chronic problem like osteonecrosis, Charcot's arthritis and hemochromatosis. Okay, now let's talk about the investigations. What are the investigations you are going to do to support your diagnosis? Okay, synovial fluid analysis. Okay, this is an investigation of choice if you think that the arthritis may be due to sepsis, it is a monoarthritis acute condition, or you think that it is a crystal associated arthritis like gout or pseudo gout. In that case, you can go ahead with a synovial fluid analysis. It is taken from peripheral joints or involved joints, and examined for cell count, gram stain and culture, all these things. Okay, and polarized light microscopy is done to find out the presence of any crystal is there or not. I have already mentioned, when do you do a synovial fluid analysis? If it is monoarthritis, if there is trauma with joint effusion, monoarthritis in a patient with chronic polyarthritis, and if you're suspecting a joint infection, septic arthritis, crystal induced arthritis, or hemarthrosis, that means presence of blood in the joint. If the effusion is hemorrhagic, okay, consider and think of trauma, coagulopathy, neuropathic arthropathy, and if there is no hemorrhage, okay, then find out the level of white blood cell. If white blood cell count is more than 2000, okay, then it is a inflammatory or septic arthritis. Okay, if polymorphonuclear cell is more than 75%, then see if there is any crystals present or not. If crystal is present, okay, it goes in favor of gout or pseudo gout. If crystals are not present, okay, there is no crystals but polymorphonuclear cells are more than 75%, then it will be inflammatory arthritis or septic arthritis. You do a gram stain culture to find out the organism involved. If the WBC is more than 50,000, then it is possibly a case of septic arthritis. If not, then it is probably a case of inflammatory arthritis. And in the cell count, if polymorphonuclear cell is less than 75%, then you think of non-inflammatory articular conditions, like mechanical conditions like osteoarthritis, trauma, or maybe some other conditions. Next thing you do is a X-ray, plain X-ray. What are the things you can know from an X-ray? You can know about the soft tissue swelling, you can know about osteopenia or osteosclerosis. You can identify a particular deformity. If there is any joint erosion, you can see joint space narrowing, you can see. If there is any new bone formation, any calcification, you can see. Okay, so these will be very much helpful in making a particular diagnosis. Depending on the deformity or depending on the joint erosion, joint space narrowing, you can really identify a particular disease. So X-ray is very much helpful. Just for example, I am showing you few X-rays. A normal joint, okay, looks like this. Okay, this is the joint space, but in this case, this is the X-ray of a knee joint, but in this picture you can see there is very much loss of joint space, which is seen in cases of osteoarthritis of the knee. So probably it is a case of osteoarthritis of knee joint. Okay, this is how the X-ray of a normal hand look like. Okay, and this is the X-ray of a patient of rheumatoid arthritis who has already developed some deformities, and you can see there are bony erosions. Okay, bony erosions, then displacement of the bone, all these things you can see. Okay, then this is probably a case of we are looking at an X-ray of gout where there is formation of tophi. Okay, we're going to talk about this tophi later on. Okay, then you can go ahead and do a radionuclide bone scan. It is highly sensitive to find out actually bone metastasis, Paget's disease, infection in the bone, and hypertrophic osteoarthropathy, which usually you see in cases of malignancy. You can go ahead with the bone mineral density. As the name suggests, it will help you knowing the density of the bone, and it is very much helpful in case of diagnosis of osteoporosis and also in the follow-up of osteoporosis patient. You can go ahead with a CT scan or MRI. Okay, but CT scan and MRI, these are helpful in cases of intervertebral disc herniation and cord compression, helpful in case of periarticular lesions, osteoarticular malignancy, etc. You can do an ultrasonography of the joint involved. It will help in identifying if there is any soft tissue changes, any fusion, any cyst, etc. Okay. For supporting the diagnosis, you can go ahead and do a blood test, routine blood test you can do. In the complete blood count, you may find anemia, neutrophilia, thrombocytopenia, all these things. CRP level will be increased in cases of this arthritis. Values more than 10 is very much significant for inflammation. Okay, and it is useful for monitoring disease activity also. ESR is not very much specific, though we can do it, and the level of ESR will be quite high. And we can do blood tests or serology for autoantibodies. Okay, there are many rheumatological diseases where there will be presence of autoantibodies. So if you're suspecting a particular disease, we can go ahead and do the autoantibody testing, and if it is positive, we can diagnose a particular disease. Okay, so this is all about how do you approach a case of rheumatology. Okay, how do you take history, what are things you're supposed to ask, then what are the examinations you're going to do, what exactly you're going to look for, and then how or what are the investigations you're going to do to support your diagnosis. Okay, I hope this is helpful for you. Thank you.